You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is September 29th, 2023. Our topic is food protein-induced enterocolitis syndrome, presented by Dr. Anna Nowak-Wegrzyn. She is a professor of pediatric at Nowak-Wegryzn School of Medicine and Division Director of Pediatric Allergy and Immunology and Chair of the Medical Advisory Board for the International FPIES organization.
My name is Anna Nowak-Wegrzyn. I'm a pediatric allergist, immunologist, and at NYU, Grossman School of Medicine, and the director of the division. So I thank you for the invitation to meet you and to talk about food protein-induced enterocolitis syndrome. I'll just update you what happened, since we've published the guidelines, and we'll talk about FPIES epidemiology, phenotypes, comorbidities, diagnosis, management, and if we have time, pathophysiology. So among all of the conditions that you're learning about, food allergies has become a very important public health issue over the past 2 decades. This is really refers to the Ig-mediated food allergy, so anaphylaxis, immediate reactions. But around the same time, we have seen emergence of this particular non-Ig-mediated food allergy called food protein-induced enterocolitis syndrome, and it used to be referred to as a zebra in the world of food allergy, and sort of looking at the milestones and the number of publications, you can see there's this dramatic increase over the past decade. In 2010, the International FPIES Association has been formed. In 2016, the ICD-10 code for FPIES has been established, and 2017 published international consensus guidelines for managing FPIES. And then in 2022, there was an NIH virtual FPIES workshop, and FPIES is included in the call for proposals regarding consortium for food allergy research. So just to give you a little of a historical perspective. So I mentioned before, it was a zebra. So we were a little bit surprised when we teamed up with Ruchi Gupta from Northwestern, who is the sort of the expert in Ig-mediated food epidemiology. And she has the model of using a population-based surveys. And in her survey, which was really focusing on IgE food allergy, there's one question saying, have you or your child been diagnosed by a physician with FPIES? Please note that this is a very uncommon condition. To our surprise, 0.5% of US pediatric population confirmed that, and even more surprising, 0.22% of US adult population reported being diagnosed with FPIES. So this is really sort of saying that this is no longer a super uncommon situation. And also from that study, it became very obvious that patients with FPIES have other allergic conditions, particularly Ig-mediated food allergy. So you can have both, so double whammy: eosinophilic esophagitis, asthma, seasonal allergies, and atopic dermatitis. So what is FPIES? So FPIES is a non-IgE mediated food allergy, which means that most of the time when we test patients, we don't have positive skin tests, or we don't detect specific IgE in the serum. And this is usually starts in infancy and has predominantly gastrointestinal symptoms. And the symptoms are forceful, projectile, repetitive emesis. They can be accompanied in more severe cases by lethargy, pallor, and later on diarrhea. So emesis starts within 1 to 4 hours, typically 2 hours. And what is very sort of classic for FPIES is that patients have no allergic symptoms from the skin or respiratory tract. So there's no swelling, itching, hives, or sneezing, coughing, wheezing. So that's what is associated with like anaphylactic food allergic reactions, and this translates into usually slightly delayed diagnosis. So patients go through at least a couple of reactions before allergy is suspected. So among all of the non-IG mediated food allergies, FPIES, to me, I sort of call it like anaphylaxis, non-IG mediated anaphylaxis. That is really an allergic emergency. And this is because the reactions can be severe. So obviously there's a spectrum and they're milder and moderate, but in severe reactions, we see patients becoming dehydrated, having metabolic acidosis, methemoglobinemia, which is due to this intense intestinal inflammation. There's leukocytosis with left shift, which frequently leads to workup for sepsis and treatment with antibiotics. There's an increase in, so there's thrombocytosis, there's elevated CRP, so very strong sort of innate immune response associated with the adaptive immune response. And in some series of patients, hypovolemic distributive shock has been described in about 15 to 20% of the patients. So kids look really horrible. Parents are very alarmed and traumatized by that event. And if the symptoms are more chronic, so, both chronic and acute reactions could lead to the dehydration and shock, but only chronic symptoms, so developing over days to weeks, usually in young infants, can lead to protein loss through the gut and low albumin total protein, to anemia, as well as weight loss or failure to thrive. So FPIES doesn't have a biomarker. It's a non-IG mediated food allergy. There's really nothing we can detect in the peripheral blood that informs us whether the patient still has active FPIES. So this is driven by the lack of sort of limited insights into pathophysiology. And you have to recognize it as a constellation of symptoms. So again, another analogy to anaphylaxis, right? Like you don't have a biomarker for anaphylaxis it's happening. After, post factum, you could check tryptase, but really you have to recognize the symptoms. But then in FPIES, this is linked to the delayed diagnosis, particularly in adults. Now, I think like we've raised awareness of infantile FPIES, but in older children, in adults, this diagnosis is frequently delayed. So majority of cases start in the first year of life, soon after introduction of the food into the child's diet. So if it's a solid food, it happens at 5-6 months, or if it's milk, it could happen earlier. But you could, as I mentioned before, FPIES can also start in adults and older children, and it's usually linked to the reactions to seafood, so fish or shellfish. And those people have eaten those foods before without symptoms, and all of a sudden they start reacting. So about 90% of the cases that we see as allergists have the acute phenotype, so 1 to 4 hours symptoms begin. Only 10%, about 10% have this more chronic presentation. And then, FPIES is classically a non-IG mediated food allergy, but there's a subset of patients which we call atypical FPIES, which actually have evidence of IgE. So they will develop, they either have positive IgE at the onset or develop it over time. So they have positive skin tests, detectable serum IgE. And there's some, as similar to other forms of food allergy, the patients with the atypical FPIES may have a more protracted course. So in the past, the atypical FPIES was most commonly reported in children with cow's milk FPIES. And in one of our studies, we estimated about 1 in 4, so 25% would develop IgE to cow's milk, and then only 1 in 3 of those patients would progress to immediate IG-mediated cow's milk allergy. However, 2/3 would remain FPIES. So sort of depending on the overall phenotype of the patient. So if it's a more atopic patients with significant eczema or having additional IG-mediated food allergies, this would be the person that we would consider at a higher risk to develop, to convert, right? Like to convert into the IG-mediated food allergy. And then adults with FPIES, we are learning more about them, mostly seafood, but there are other foods also, like dairy, wheat, egg, or even soy. And adults with FPIES, the most constant feature is a dramatic and very severe abdominal pain associated with nausea, vomiting, even loss of consciousness in some patients. But everybody has this horrible abdominal pain. So the most information about FPIES in older patients comes from Spain, and you can see that this abdominal pain is the most constant feature. Another sort of points worth making is that those are young adults, and then the vast majority of them are female, 88% in that case series from Spain. Which is really strikingly different from infantile FPIES, where there's a slight male predominance or equal sex distribution. And it's quite, consistent with other allergic conditions, asthma, that is adult onset asthma, more common in females. So majority of the reactions are caused by crustaceans, and 60% will not have a cross-reactivity to fish, but 40% will cross-react with other seafood, and even higher for other crustaceans. So this is sort of relevant when advising patients which foods they can eat or not. The survey of focusing on FPIES in adults uncovered big variability in practices managing the patients, and that sort of also indicated that the updated guidelines for FPIES should focus more on should incorporate specific guidelines for adults. So any food can cause FPIES, right? Any food can cause Ig-mediated food allergy, but some foods are more common than others, and those are usually foods that are being introduced early, so in the first year of life. Now, in the US, the single food group is cereal grains, with oats, rice being followed by wheat, barley, quinoa. And this reflects sort of, like how common oats have become as the first solid foods for introduction in babies. This is followed by cow's milk, then vegetables, among vegetables, sweet potato, then fruits, which is most common are avocado, banana, apple. And again, avocado has become very popular weaning food. And there are others. And, more recent data from Michigan underscores that egg and peanut have become more common in the US, following milk and cereal. So globally, milk remains the most common trigger. And fish, and particularly is common in Mediterranean countries, in Spain and Italy, which points to the importance of the dietary sort of environmental factors, which foods are being introduced. And my own patient population at NYU would suggest that we are seeing really higher rates of peanut FPIES. So cross-sectionally comparing with the data from CHOP from years 2007, 2012, I would say there's at least like 7-fold increase in peanut FPIES, and about 3-fold increase in egg FPIES. And sort of this is curious, right? And similar observations regarding egg have been reported from Japan, where they, in the red, you can see the cases of egg FPIES in 2018, 2019, compared with the cases in light gray from 12 to 2013, and there's only a dramatic increase in egg really over that period of time. Again, perhaps reflecting our the guidelines to introduce egg and peanut early for prevention of Ig-mediated food allergy, which still, is a valid recommendation considering how much more common Ig-mediated food allergy is, but raises questions whether, there's whether we could uncover some risk factors for babies to develop FPIES to egg or peanut. So those are empiric diagnostic criteria which patients should meet to be formally diagnosed with FPIES. So first is vomiting in 1 to 4 hours, of an absence of respiratory symptoms and skin symptoms for acute FPIES, and then at least 3 or more minor criteria, same more episodes of the same food or other reactions to another food, lethargy, pallor, emergency room visit, need for intravenous fluids, or diarrhea that starts usually within 5 to 10 hours, but it's not the most constant feature. So chronic FPIES is much more problematic because the only way you could diagnose chronic FPIES would be through challenge, which would mean that you eliminate the food suspected to cause FPIES, and then when you re-challenge it, a person couple days or couple weeks later, they would redevelop acute symptoms, and this is based on the work, initial work that defined FPIES and the infants who were being fed in the hospital were evaluated for chronic symptoms, and then the feeding was stopped and they were put on IV fluids, and when they were like 3 days later re-challenged to the milk or soy, they developed vomiting within 1 to 4 hours. So without that re-challenge, diagnosis is presumptive, and I would say it's 100% of the cases because the parents do not want to challenge their children who ended up in the hospital or even in the intensive care unit. So how do we, but if we challenge mostly not for the initial diagnosis, but to evaluate for resolution of symptoms. And here's a little bit also of a conundrum because there's no like universal standardized food challenge protocol. Since the symptoms are delayed, the dosing could be as a single dose, or due to this sort of billing issue in the US where you have to have at least 2 doses to call a procedure a food challenge, like we usually split it in at least 2 doses. Challenges for range reduction are done usually under physician supervision, either inpatient or outpatient. Older studies have underscored that this is a potentially high-risk procedure, and then that IV fluid should be available for the patients, with up to 50% of challenges being treated. However, the more recent data suggests that this is not true anymore, that a vast majority of the case of the patients resolve with oral rehydration and oral ondansetron or IM ondansetron, antiemetic. So this will have to be refined. And there's, the dosing and calculating the total dose. But the challenges happen over 1 day because we don't have the ability to challenge the people, over consecutive days. But the observation is longer, right? It has to account for the delayed symptoms, so up to 6 hours. And then post-reaction, the patient should be well tolerating liquids. So this makes for a long day in the unit. So this suggests that, it would be might be reasonable to maybe simplify the protocol, and the CHOP has pioneered the protocol with 1/3 of a dose for age, and it seems to be safe. The patient who tolerate that amount initially are then asked to introduce the food at home. And most of them did it successfully. And the survey we've done and published in 21 really highlighted the heterogeneity of approaches, to food challenging FPIES, and really very few very few physicians offer challenges to FPIES in their practices compared to those who report IgE, challenges for IgE-mediated food allergy. There are, big variability regarding where the challenges are done, whether the IV access is secured before the challenge, what is the total dose, regular serving based on grams of protein or partial serving, and then whether people give it in 3 equal portions over 30 minutes or, 1 portion. So this is just to underscore the need for more consensus. But in terms of the management, FPIES can be a medical emergency. So patients who have a more severe phenotype respond very well to fluid resuscitation with intravenous fluids. And the patients who really look unwell, are hypotensive, deserve that treatment in the emergency room. But milder phenotypes, milder reactions could be managed with oral rehydration at home, with oral ondansetron. If it's more severe reaction, we sometimes use methylprednisolone to dampen the severe inflammatory response. Of importance is that FPIES reactions are managed without epinephrine or oral antihistamines. And so we usually do not prescribe epinephrine autoinjectors to the patients with FPIES unless they have atypical FPIES or they have history of anaphylaxis to other foods, and we worry about that because we know that epinephrine doesn't work. In IG-mediated food allergy, if you have a patient during a challenge who develops abdominal pain or vomiting, giving them a dose of epinephrine really helps tremendously and very quickly. And there are some patients that can definitely manage their reactions at home. Those who had prior severe reactions that were treated with intravenous fluids in the hospital or admission or in the emergency room or were admitted overnight, those patients should definitely be seen in the emergency room. So, so for the patient, we would say oral ondansetron based on empirical evidence and some limited evidence from clinical trials, and then clear liquids or breast milk in small babies with ice strips or a really small amount, 1 teaspoon, waiting about 20 minutes after a vomiting episode. And we are working within the Quad AI on a FPIES action plan, so similar to the anaphylaxis action plan that can be provided, can be signed by a physician and provided to the school, because now with more patients, more children, you know, requiring this, there's a big confusion what medications are necessary for the patients. For the long-term dietary management, the avoidance is the mainstay. There's really no therapeutic approach other than that. But usually patients react to more than a trace amount. So there's no need for avoidance of precautionally labeling or trace amounts of foods unless there's this unusual patient who really, you know, had horrible symptoms after licking something that may be contaminated with the food. So there are some patients with FPIES who can tolerate baked milk and baked egg, but unless, you know, they're already coming to you with the, you know, reporting tolerance, then you would need to do that introduction under supervision or in the office, or sort of guided introduction at home if they had very mild symptoms to liquid milk or concentrated egg in the past. You may know by now that among IgE-mediated food allergy, majority of the children tolerate the milk and egg in the baked form. I don't think this is going to be true for FPIES. There could be a subset, maybe, you know, about 30% would tolerate it, but I've also had patients who reacted to baked milk with very serious reactions. So when babies are breastfed, we don't restrict maternal diet unless there are symptoms. So, you know, our baby is not thriving. But otherwise, there's no need to avoid rice or oat or, you know, peanut from the maternal diet. For babies who reacted to cow's milk or soy, hypoallergenic formula is the best choice. So in the US, it's usually extensively hydrolyzed casein or whey-based formula or amino acid-based formula, so elemental diet. In countries where extensively rice hydrolyzed formula is available, it tastes better, so it might be an alternative, but it should not be used for babies with rice FPIES. It is really helpful if you have access to the registered dietitian who has an experience with food allergy to refer the patient, because there's usually questions about the sort of, you know, the specifics, the details of introduction, and, you know, sometimes babies with FPIES have actually, they have more risk for having feeding difficulties compared to IG-mediated food allergy. So, so, you know, the simple food introduction may not be that simple. And when you're choosing a food to introduce to a baby that had an acute FPIES reaction, it is helpful to sort of, you know, keep in mind this potential co-reactivity. And we don't want to delay introduction of solids. In the past, there's and especially in babies who have had reactions to multiple food groups, the delay of solids was severely was significant, and those infants were at high risk for developing feeding issues. And of course, monitoring growth is important. So during the pandemic, we came up with like a schedule for gradual introduction of new foods at home, and this might be adopted for the for timing right now. Parents usually like having a specific advice, how to do it. And, for some, you just say, okay, introduce it over 3 days and they're fine. Some others like how much, how frequently, is a half teaspoons, etc. So you could use that to really provide those specific instructions. And the 2017 guidelines had sort of a template or blueprint for introducing the foods starting from lower risk through moderate and higher risk foods. But as you may notice now, avocado has emerged as the lower food, risk, as the higher risk food. So, and also these guidelines, recommended delayed introduction of milk and peanut and tree nuts and egg, which, right now this is not aligned with the official guidelines. So, if you ever use that kind of table, you have to update it for the with the current approach. So so there are, as I mentioned before, some subset of patients with FPIES to milk and egg might tolerate baked egg diets, and there's only one single report of successful IT in an older child with egg FPIES. So potentially there's a space, there's a room for doing this kind of a treatment. Although probably by now that one of the side effects of oral immunotherapy is gastrointestinal inflammation, even to the point of inducing EOE. So certainly the patients with FPIES would be considered higher risk. With all that being said, FPIES is a generally favorable diagnosis. Patients, start tolerating the food by age 3 in vast majority of the cases. You can see on the left a graph from the Israeli birth cohort focusing on milk. So by age a year and a half, 7. So by age 1, 1 year, 50% tolerate milk, 75 by age 1.5, and 90% by age 2. The table just compares different studies, and just to point out that there is one exception to the rule that vast majority of infants outgrow their allergy by age 3. It's the fish. So studies from Spain suggest that only minority, less than 30% of children will outgrow fish FPIES by age 5. A study from Australia, which I'm not sure, I don't think I'm quoting it here, suggested that also egg tends to be outgrown at an older age. So they suggested waiting with the introduction in those patients with severe symptoms until age 5. And we don't know what is the optimal timing for reintroducing peanut or tree nuts in FPIES, so TBD. Adults' natural history is really poorly understood, but the studies from Spain suggest that rather low rate of tolerance over a period of 3 years in the larger study. So it's probably more of a more persistent condition. And when I was discussing this population-based study, I mentioned that there's a lot of atopic comorbidities in patients with FPIES. And this has been confirmed by the study from CHOP and other studies from different patient population, suggesting that patients who have FPIES are really at high risk to develop concomitant IG-mediated food allergy to other foods, not to the FPIES food. They have high rates of atopic dermatitis, asthma, and allergic rhinitis. And in the same population-based study, when we looked at the EOE patients, the rates of FPIES among patients with EOE were significantly much higher than for patients without EOE, again, putting it on a spectrum of the allergic diseases. So how much do I still have time, or should I just stop here and take questions?
It's totally up to you, but we still do have some more time, though. Yeah, I mean, it's totally up to you.
So maybe I'll just tell you very quickly about the studies we've done on immunopathology of FPIES. So So with my collaborator, Dr. Cecilia Berrien from Northwestern, previously Mount Sinai, we have been studying FPIES in the setting of an oral food challenge. So we would obtain blood prior to beginning the feeding, and then at the onset of symptoms, and then at 4 hours, and we would look at the markers in the peripheral blood to gain insight into pathophysiology. The challenge with the FPIES is that symptoms are self-limited for the acute reaction, so there's really no indication to perform endoscopies, biopsies in those individuals, which could give us more insight into the target tissue. But what we have found over the years is that there's really no humoral aspect to FPIES reaction. So we looked at IgE, IgA, IgM, Ig, even free light chains, and we couldn't find anything specific in the cow's milk FPIES. But what we found was that there's really very broad systemic innate activation, as well as pan-lymphocyte activation 4 hours after symptoms onset. So there was, activation of neutrophils, of monocytes, and eosinophils, as well as lymphocytes. And when you look at the proteomic analysis in the peripheral blood, the most common biomarkers were Th17 pathway, so IL-17A, 17C, and CCL20. And those were made by T cells. So this suggests that those are allergen-specific T cells. So this is an adaptive sort of arm of that response. But also those innate cytokines from monocytes were increased. So IL-6, IL-10, oncostatin M, leukemia inhibitory factor, and TNF-alpha. And in the metabolomic analysis, we found elevated inosine. And this elevation was correlated with Reg1 alpha, which is a regulator of mucosal barrier function, which is also upregulated during classic food allergy. So there is definitely a big local inflammation, and sort of taking empiric evidence on the efficacy of ondansetron, so serotonin antagonist. We looked at the serotonin pathway in FPIES, and we indeed have shown increase in peripheral blood serotonin precursor at 4 hours in the patients who were symptomatic. And then we also shown that if we stimulate biopsies from duodenum and stomach with the adenosine, so purine, the purine, we see increased production of serotonin, providing the support that serotonin is an important mediator. All right, so in summary, FPIES is a non-Ig cell-mediated gastrointestinal food allergic disorder. The prevalence estimates in the US are 0.51% of children, 0.22% of adults, which is much higher than we've previously estimated. FPIES has different phenotypes: acute, chronic, with acute being the predominant phenotype seen by the allergist. Atypical is Ig positive and then adult onset. And then, the triggers are the first foreign food proteins introduced into the infant diet. So cow's milk, cereal grains, certain fruits, or, Italy and Spain, those could be fish. Adult FPIES is usually triggered by seafood, and although there are some anecdotal reports of other foods such as eggs, soy, dairy, and wheat. And FPIES is definitely on a spectrum of the allergic diseases with frequent Ig comorbidities: food allergy, asthma, allergic rhinitis, as well as eosinophilic esophagitis and atopic dermatitis. So those patients should really be under the care, under the guidance of the allergist, because they will go on to develop additional conditions. So we got the grant from NIH to study immunologic basis of FPIES last year with Cecilia Berrien and Mary-Grace Baker from Mount Sinai. And thank you very much for your attention. And if you are in New York, come and visit me at the Hassenfeld Children's Hospital in Manhattan. Thank you. And I'm happy to take any questions if you have.